Module 8, Gastrointestinal. This recording will cover Chapter 59, Coordinating Care for Patients with Hepatic Disorders, and Chapter 60, Coordinating Care for Patients with Biliary and Pancreatic Disorders. So we began with the liver. So the liver has 500 plus functions, over 500 things that the liver does to maintain homeostasis in our body. So many functions that we don't even know everything that it does. So we can't live without a liver. There is no liver machine that can take its place if our liver fails. So this slide just shows some of the things that our liver does. It detoxifies, it metabolizes, it produces cholesterol, it stores micronutrients, it helps to maintain our blood sugar balance, it produces bile, very big in protein synthesis, and it has a huge role in our immune system. So I wanted to add in a little bit of a definition so you can read through this. You should know this. I think you guys know most of this. Bile production, I'll just read a couple of these. Bile helps in the small intestine to break down and absorb fats, cholesterol, and some of the vitamins. The liver supports blood clots, so vitamin K is necessary for the creation of certain coagulants that help clot the blood. Bile is essential for vitamin K absorption, so they go hand in hand. It's created in the liver. Fat metabolization, so bile breaks down fats and makes them easier to digest. Filters the blood. The liver filters and removes compounds from the body, including hormones such as estrogen and aldosterone, and so on. So please read through this. It tells you the major functions of our liver. So here's that picture again, picture of our liver. It has a right and left lobe. This is the anterior view. If you looked at its underbelly, you can see that the gallbladder is hiding under there. It's not part of the liver, but it's its little neighbor. And the gallbladder is what stores the bile that the liver produces. And one thing to note is that the liver is made up of millions of hepatocytes, which are liver cells, hepatocytes. And those liver cells are the workers. They're the ones that metabolize, detoxify, and create the protein. Okay, so remember that, hepatocytes, millions of hepatocytes in the liver. All right, so we're going to start out with hepatitis. So the word hepatitis, inflamed liver, infection of the liver. So causes, most common is going to be viral. We have A, B, C, D, and E, viral hepatitis. Alcohol, some medications, chemicals, some autoimmune diseases, and some other metabolic problems can also lead to hepatitis. So we're first going to start with hepatitis A, or HAV, hepatitis A virus. So this is not a chronic disease. There is a vaccine available. Okay, say it again, hepatitis A, there is a vaccine available. It's transmitted through the fecal oral route. So you see this picture, go to the toilet, have a bowel movement, don't wash your hands, you touch your food and you eat it and you can get it. So this is the one that can have outbreaks in restaurants. So this can cause mild flu-like symptoms. It can lead to jaundice, and in some seldom cases, it can result in acute liver failure, but no chronic infection. So lab-wise, IgM equals acute hepatitis, so you have an active infection. If you have IgG, it could mean that you're almost wrapping it up or you had a past infection. IgG antibody provides lifelong immunity, which is good. So for this one, you want to educate to vaccinate because we have a vaccine, and to hand wash. Some sources of infection can include contaminated food and water, likely to happen in crowded conditions like a daycare or nursing home, poor hygiene, poor sanitation. Then we move on to hepatitis B. This one could be an acute infection or a chronic infection, and again, this one also has a vaccine. So this one, the people that are at risk are those that have unprotected sex, they live in a household, and they are in contact of somebody who is chronically infected, patients who are on dialysis, IV drug users, healthcare workers like you, and recipients of blood products. So lab-wise, HBsAg shows active infection, anti-HBs shows past infection, or if you had the hepatitis vaccine. And then the anti-HBc shows a past or present infection. So this can also be transmitted to infants by mothers who are infected with hepatitis B. Small cuts on mucosal surfaces that are exposed to infectious blood or blood products, and also bodily fluids like semen and vaginal secretions can also infect hepatitis B. So with hepatitis B, the patient should actually be on standard precautions. Okay, so also it's the same for hepatitis A. If a patient happens to be in the hospital, you're not going to put them on any type of special precautions. It's standard because you can't transmit it by touching the patient. Again, hepatitis B, standard precautions. Hepatitis C, now this is the one where we do not have a vaccine for, unfortunately. And there's a 15 to 20-year delay between infection and manifestations of liver damage. So you may have the infection and then it goes away, the signs and symptoms, but it's brewing inside your body, and then your liver is becoming damaged until you see the next clinical manifestations happen years later. And just to note, hepatitis C is the most common cause of liver disease and the most common indication for liver transplant in this country. So an acute infection will be asymptomatic, no signs and symptoms. Chronic is going to lead to major liver damage, no vaccine available. So some risk factors here: unsafe injections and medical procedures, unsafe sex, mother-to-child transmission, and injecting IV drug use. Other two uncommonly known viral hepatitis are hepatitis D and hepatitis E. So hepatitis E is unique where it has to have hepatitis B to replicate. So if you don't have hepatitis B, you can't get hepatitis D. Hepatitis E is very similar to our hepatitis A in other countries. So it's also the fecal-oral transmission, but there's not that many cases here. It's typically found in developing countries. So some general information about viral hepatitis. So if you have an acute infection, then a lot of your hepatocytes, your liver cells, are going to be destroyed. But liver cells can regenerate, and they will regenerate once the infection is gone. In a chronic infection, it's going to lead to fibrosis, and it can progress to cirrhosis, where the liver is almost completely fibrosed. This table 59.1 shows the types of hepatitis. It's from your textbook, so you can kind of read through that. What you want to pay attention to is how the virus is transmitted, whether we have a vaccine, and then the education that we want to tell our patients. So this next slide covers, generally speaking, general hepatitis clinical manifestations. So the acute phase of hepatitis usually lasts between 1 and 6 months. Anything longer than 6 months is considered chronic. So here on the left-hand column, there are a lot of signs and symptoms, and these are all related to the functions that the liver does. So if you have an impaired liver, all of those 500 plus functions are going to be affected. So here we have anorexia, which is loss of appetite, and clay-colored stools. So why would we experience clay-colored stools? So if the liver has an obstruction, the bile that it produces are not excreted in the stool. So this is going to result in a color change of the stool. It's going to turn clay color. Now, it doesn't mean that every hepatitis is going to experience an obstruction in the liver, but usually if a patient has jaundice, they will usually have clay-colored stool. And jaundice is when the liver isn't able to metabolize and excrete bilirubin, and that's going to result in elevated bilirubin levels in plasma. So one note, bilirubin is a byproduct of breakdown of red blood cells, and that's something that the liver does. So that is kind of like what's going on there. So I highlighted the signs and symptoms that your textbook emphasizes, but all of these things could happen, and every patient's a little different. So the way hepatitis is diagnosed is by the presence of those antibodies that I mentioned earlier. We also check liver function, so AST, ALT, and albumin, because the liver produces albumin. There can be further genotype testing specific to the virus. We can check those head-to-toe physical assessment findings, liver biopsy, a fibroscan, and a fibro test. This is similar to an ultrasound that can detect fibrous tissue. I included this here so you can read on what the lab you're looking at does for the body. So like, for example, AST, aspartate transminase, is an enzyme that helps metabolize amino acids. So anyway, when you look at labs, you can kind of say, oh, this is what this means, this is what I'm looking at. So teaching. So when you have hepatitis, there's many hepatocytes that need to be repaired, and our liver knows how to repair them, but it needs rest and it needs adequate nutrition. So patients that have hepatitis need to make sure they're eating adequate, small, high-calorie meals because they don't really have an appetite. Remember, anorexia is one of the clinical manifestations, so we need to encourage high-calorie food so that the body can regenerate those hepatocytes, and rest. Rest is also very important. So they may benefit also from vitamin supplements. They should practice hand hygiene, especially if the hepatitis they have is transmissible, like a fecal oral route. Avoid high-risk behaviors if applicable, like for Hep A and Hep C, those IV drug use or unprotected sex. And vaccinate. Make sure that if we have a vaccine for it, then they should take advantage. So Hep A and Hep B have vaccines. So that is part of our health promotion. Again, remember, hepatitis A, hepatitis B, vaccines exist, so we should educate on that. Nutrition. So for just generic hepatitis, there is no special diet. Pretty much we just want to encourage a well-balanced diet that the patient can tolerate, because maybe they're not going to feel like eating. High calories, we may need to reduce the fat content, because if they're having issues with bile, then the bile is what helps to break down the fat. So we don't want to put too much fat in there if they're not going to be able to break it down. Some vitamins, they may need enteral nutrition depending on how bad the hepatitis is. Small frequent meals, carbonated beverages are all actually suggested, and adequate fluid intake. So this is a table from your textbook, table 59.3 of medications that are used to treat the different hepatitises. So for the most part, most of the meds will be covered in your pharmacology class, but for hepatitis A, you can see that there are no medications because it's just supportive measures. This is self-limiting and it should go away on its own. It just kind of runs its course. For hepatitis B, there are oral and injection options. These are antiviral medications. So the first one here, tenofovir, you should know that for sure. It's a very commonly used medication for Hep B. And then Hep C, you can kind of read through these. Moving on to the pancreas. So the pancreas in this picture, and here is actually a picture of a real pancreas, kind of looks like a chicken fillet. It has a very important role, another very important organ in our body, and an important organ that works in tandem with our GI system. So the pancreas has two functions. Again, this should probably be a review for you. You've took anatomy and physiology. The pancreas has two functions, endocrine and exocrine. So the endocrine part is the release of hormones. So insulin is one of them. And then the exocrine is the secretion of digestive enzymes. So right now we're focusing on the digestive part, so the enzymes. And here is our picture of the pancreas. This is our duodenum. Okay, so our stomach would be up here, right, connecting to our duodenum. Our food comes down the intestine here, and then there's this little duct here. And one side of this duct goes to the pancreas, and the other side goes up to the gallbladder. This is the bile duct. So when the food comes down, our body senses it, and the pancreas will secrete digestive enzymes, it will secrete insulin, and our gallbladder will secrete bile, and it will meet the food here so that it can be further processed. Here's the list of our digestive enzymes. We have amylase, trypsin, and lipase. Like any other organ, our pancreas can become inflamed and infected. So let's talk about acute pancreatitis. So this happens when our pancreatic enzymes spill out of the pancreas into the surrounding pancreatic tissue, and it causes autodigestion and severe pain. So the pancreas is literally breaking down itself. It can vary from mild edema to severe necrosis. So think about it. You have this pancreas. Let's look at this picture down here. So the food comes down, and that's going to trigger our pancreas to release the enzymes. So here's the pancreatic duct. It releases the enzymes, but for some reason, the enzymes are unable to leave the pancreas. It should go down the duct and meet the food in the duodenum, but for some reason, maybe there's an obstruction here of some kind, but those enzymes just stay right there in the duct, and they begin to digest the pancreas. Very, very painful. So the causes, it can be related to gallbladder disease. That's the most common cause in women. And chronic alcohol use is the most common cause in men. Some other less common causes could be related to medication or maybe pancreatic cancer, trauma, or hypertriglyceridemia. Here's a little visual that you can kind of see on what it leads to. So signs and symptoms of acute pancreatitis. Pain for sure. This is considered to be one of the most painful conditions. So abdominal pain is the predominant sign and symptom. Patients will complain of left upper quadrant or mid-epigastric pain that radiates to the back. It has a sudden onset. It's deep, it's piercing, it's continuous. It worsens with eating. So let's think about why that is. So your pancreas is going to secrete enzymes when you eat. So if you're eating, it's going to secrete the enzymes, and if there's nowhere for the enzymes to go, it's going to start auto-digesting. So you can already see that one of the things that we're going to have the patient do during pancreatitis is not eat, so we can reduce the stimulation. Not relieved with vomiting. There's a lot of other things that can result, so abdominal fullness, hiccups, dyspnea. So the pancreas is kind of interesting. When these enzymes kind of inflame the pancreas sometimes starts to inflame the liver, and then the liver will get inflamed, and then the lungs will get involved. So it kind of spreads around. So sometimes you'll have respiratory signs and symptoms too. These patients may have decreased or absent bowel sounds, hypotension, jaundice, crackles in lungs. They can develop these Gray-Turner spots or Gray-Turner sign. So sometimes this is caused by hemorrhaging, but sometimes the enzymes can cause weird things to happen in the body. Okay, so what you need to know, this is a lot of information. So just remember, abdominal pain is going to be number one. Eating worsens the pain, so we want them to stop eating. They need to be NPOs to rest the pancreas until it stops, until we can figure out why those enzymes aren't going where they're supposed to go. How do we diagnose acute pancreatitis? We're going to, of course, do our good H&P. We're going to draw labs. All of our enzymes, our digestive enzymes, will likely be elevated. If not, for sure, lipase will be elevated. Okay, so lipase is the most commonly to be elevated at the beginning of pancreatitis. Our liver enzymes, our triglycerides may be elevated also if the inflamed pancreas also starts to affect our liver. We could have elevated blood glucose levels, and that's because if you remember the pancreatic duct that collects the enzymes that's secreted and then hopefully will dump it into the duodenum, that same duct also carries insulin that the pancreas secretes. So if there is an obstruction there and those enzymes can't get out, well, the insulin isn't going to be able to get out either. So the body isn't going to be able to get insulin, so their blood glucose is going to rise. Elevated bilirubin, decreased calcium. Some patients, if they have liver involvement, will have increased bleeding time, so increased PT and APTT. Abdominal ultrasound, X-ray, CT scan, something called an ERCP. So all of these things can be done to diagnose acute pancreatitis. We're going to take a look now at a video of an ERCP.
This is a video of an endoscopic retrograde cholangiopancreatography, or ERCP. A duodenoscope is used. This is a specialized gastroscope with side-mounted optics and a working channel. The patient is placed in the prone position. The scope is inserted through the mouth and brought down to the ampulla of water in the duodenum via the stomach. Here we see the ampulla where the common bile duct and pancreatic duct open into the duodenum. A catheter is brought down in the instrument channel of the scope and jiggled into the bile duct. When the catheter is in the correct position, contrast fluid is injected to visualize the bile duct system with fluoroscopy. Here we can see the scope, the catheter, and the bile duct with multiple blockages. A guide wire is inserted into the catheter and the catheter is removed. A special brush is inserted over the guide wire and brought into the bile ducts. Here we can see the guide wire and the brush. The narrow ducts are brushed to clear the blockages and collect material for cytopathologic analysis. The procedure is finished. The brush and brush fluid are put in a test tube. In some cases, it may be necessary to place a stent in the duct to dilatate narrow passages. Here we see the placement of a self-expanding metallic stent in the ampulla of water. After the placement, bile flows freely from the ampulla. Here, the stent is visible on an X-ray.
Okay, I hope you enjoyed that video. I think that's amazing modern medicine. So this is another table from your textbook. I really like it. It's table 60.1, and it gives you a very simple explanation of why your lab values would either be elevated or decreased. So you can kind of read through this on your own. So what are we going to do for this patient? So we want to provide pain management. We want to correct any fluid and electrolyte imbalances that they may have, and treat infection if one is present. So here, aggressive hydration. These patients are going to get lactated ringers. They're at risk for shock and they may end up needing dextran or albumin. Pain management, IV opioids, because remember this is a very painful condition. It may be paired with an antispasmodic to kind of just relax that pancreas. Side lying position with the head elevated 45 degrees is best, and we want to provide frequent oral care. We want to decrease pancreas stimulation. So the patient should be NPO. They will likely have an NG tube in place because we don't even want the gastric secretions in there, because even that can stimulate the pancreas to secrete enzymes. Also, being in pain can cause restlessness. That can increase the metabolic rate and stimulate the pancreas too. So the pain management is also partly to keep the patient comfortable, but partly because we want to decrease that pancreas stimulation. We want to decrease acid formation, so antacid, H2 receptor blockers, PPIs. And then if they develop metabolic problems, like I mentioned before, oxygen, and we may want to monitor their oxygen levels and their blood glucose levels. So some common fluid and electrolyte balances with acute pancreatitis related to vomiting, gastric suction. We could have that low chloride, low sodium, and low potassium levels. So education. Patients should not smoke because nicotine can stimulate the pancreas. We want to reduce fat or even restrict it altogether because that can stimulate the pancreas. If they are going to eat something, then carbohydrates would be what is the best choice. They should avoid crash dieting that can precipitate attacks. And then the patient should look out for signs and symptoms of infection or high blood glucose levels, steatorrhea, which is foul-smelling frothy stools. And patients may need some exogenous enzyme supplementation. So they may need to take pills that have enzymes in them, and we'll talk a little bit more about that later. So these are medications that are approved for acute pancreatitis, and what I want you to take note of for the NCLEX. So this first one here, it says morphine sulfate in the textbook, and it treats pain. However, if you look in some NCLEX study books, it says that morphine is actually contraindicated in a pancreatitis because it causes spasms, and that can actually increase the pain, and that dilaudid is preferred. So this is not a question on your exam, but if you look in NCLEX study books on this, it's going to tell you not to use morphine for pancreatitis. Then we have chronic pancreatitis. So this is when it's been happening for a while, and repeated prolonged inflammation causes fibrosed tissue of the pancreas, which is kind of like scar tissue. Causes of this, kind of similar to acute pancreatitis: alcohol, gallstones, tumor, autoimmune pancreatitis, cystic fibrosis can also lead to this. So signs and symptoms: pain, malabsorption, diarrhea, and so on. So diagnosing, it can be difficult to confirm. Same labs, a good history and physical. So management: pain meds, nutrition, no smoking, pretty much all the same management interventions for acute, but for chronic, they're definitely going to have pancreatic enzyme replacement. So that is one difference. And that's going to include amylase, lipsin, and trypsin, because all of those are needed to break down what we eat. So what I want you to remember with this one is that the education that you're going to provide on when to take that medication. So if you need pancreatic enzymes to break down the foods, when should the patient take that medication? It should be taken with food, because if you're not eating, you don't need to take them, because the whole point of those enzymes is to help break down the food you're eating. So patients should be educated to take that enzyme, those supplements, with the food they're eating. And then the patient may need to have surgery if something is obstructive, or there's cancer or something like that. Okay, leading us into the next condition, pancreatic cancer. So pancreatic cancer, the cause is unknown. There are a few risk factors: age, African American descent, and being a male. Signs and symptoms: jaundice, flatulence, dull aching pain in the epigastrium, loss of appetite. Those are your diagnostic studies. Unfortunately, there's poor prognosis for pancreatic cancer, and most patients will die in less than a year of diagnosis. The 5-year survival rate is very low, only 8%. There is a procedure that can be done if the cancer is in a specific area. So if you look at this picture, this is a Whipple procedure, and this is very, very high risk surgery. So look at the pancreas here. This is before surgery. After surgery, that's all that's left, because we don't have, again, a machine that does everything that the pancreas does. It's a very vital part of our body, so we just can't remove it completely. So we try to save as much as we can, and here you can see they left a little piece of it. This is a very high risk surgery, and the patient may not even survive that surgery. So in addition, they may have chemo and radiation. Moving on to the gallbladder. So the gallbladder is an accessory organ. It stores and concentrates the bile that the liver produces. And as a recap, that bile drains into the duodenum via the common bile duct, and that's going to help in digestion and fat absorption. So in this picture, here's the bile. Here's the bile in the gallbladder. It goes down the bile duct down here where it will meet the food in the duodenum. And this one here is the pancreatic duct. So bile is a mixture of cholesterol, bilirubin, and bile salts. So our first condition is cholelithiasis. These are gallstones. And typically you don't even know they're there until they cause a problem. They get lodged somewhere and they cause an obstruction. The cause is unknown. There's several different types of gallstone composition. And there's some pictures here. So risk factors include obesity, rapid weight loss surgery, a high-fat diet, genetics, and medications. Here we have the 4 F's, being female, 40, obese, and fertile. Here's an unhappy gallbladder. Here's an unflamed gallbladder. So this is cholecystitis. So now our gallbladder is inflamed. And we're going to have epigastric or right upper quadrant pain, rebound tenderness. We're going to have a positive Murphy sign, which we'll see a video of that next. Restlessness, fever, tachycardia. We can do ultrasound, x-ray, ERCP. We're going to look at our labs. Complications, this can lead to gangrenous cholecystitis, pancreatitis, all kinds of stuff. So let's watch the video of Murphy sign, positive Murphy sign.
Murphy's sign. Ask the patient to exhale while palpating the gallbladder area medial to the midclavicular line. Now instruct the patient to take a deep breath so the gallbladder is pushed down and against the examiner's fingertips as the lungs expand. If cholecystitis is present, the patient will experience a sharp and sudden pain, causing them to abruptly cease inhalation. This reaction is known as a positive Murphy's sign.
Okay, so now you know what positive Murphy sign looks like. So treatment management for cholecystitis depends on the stage of the disease. There may be an oral medication that can be taken to break up those gallstones. They may need to do an ERCP, which is that previous video we saw about with the pancreas. They can do shockwave lithotripsy, where they put a shockwave to break up the stones so the stones can just kind of pass on their own. These patients will need an NG tube if they have severe nausea, vomiting. They may need, just to get their gallbladder removed, a cholecystectomy. And we want to make sure we provide opioids for pain control, possibly anticholinergics to decrease GI secretions and to counteract smooth muscle spasms. If they have an infection, then they'll need antibiotics. So here's an example of either an open or a laparoscopic cholecystectomy. And you can kind of read through that on your own. Post-operatively, it's just like any other abdominal surgery. No heavy lifting, maybe need a low-fat diet for a few weeks. You want to assess for vital signs, pain, bed rest, NPO until the return of gag reflex. Ambulatory care, teaching about the diet, low-fat diet. They may need to lose weight if they're overweight. They may need to take fat-soluble vitamin supplements because they no longer have a gallbladder that holds the bile, which is what helps to break down fats. And then, of course, what they should report to the doctor after surgery.